And this is Lynn Robertson, and I'd like to welcome back those that are returning, having participated in the very invigorating, and I learned a lot this morning also, morning cab session. And this afternoon, we are really hoping that there's a lot of interaction between groups. This is an opportunity which we don't often have at our quarterly meetings to really work with each other in, as a one big group, as opposed to just within our small groups, and hopefully sharing best ideas and practices and ways to keep moving forward to achieve your goals that you have set within your groups for the various cancers and other issues that we are dealing with. Paying particular attention to such things as maybe you're the HPV group, for instance, and is there a role or is there something that policy could help you do? Or disparity should go across all of the groups. Are we paying attention to these things? What about marketing or communication? So really be trying to think more globally and not just within your small group. Okay, Kate, can you advance the slide? Hello?
Hi, Lynn. Did it advance for you? It should say PCC organizational structure.
No.
Okay.
Maybe it's me.
No, we're gonna kind of stop and start it with the PowerPoint. Sometimes technology.
Sometimes they freeze.
So we're gonna do that again. If you bear with me, I will get it right back to where it needs to be.
That's quite all right. You should have seen me last night. Oh my God, it kept disconnecting when I was speaking.
All right.
Oh, technology.
Okay. Here we go. Should say.
All righty.
All right.
I know some of you may well be familiar with the organizational structure of the PCC, but I'd like to at least bring your attention to it so that you can see here. I want to go over the chart because these are things that are important and also some things that come up when evaluation occurs, that people aren't familiar with certain things. So you can see that the Pennsylvania Cancer Coalition, we have the executive team on the top, which is made up of a lot of the PCC co-chairs, subcommittee chairs, etc. And then we have the subcommittees, which is communication, disparities, evaluation, membership, and policy. And those committees are there. Yes, they have a function on their own, but also to help and interact with the priority areas or the work group, which is prevention, which includes HPV and lung health, screening and early detection, which is colorectal cancer and men's health, diagnosis and treatment, which includes genetics and genomics, and then quality of life, which includes survivorship. Next slide, please. So within the structure, we are governed by CAB bylaws. And I don't know how many of you are familiar with those, but they are there. And they do get reviewed periodically also. There's an executive team that, as I alluded to earlier, is comprised of PCC co-chairs, priority area leads, subcommittee co-chairs, and the CCC program director. And we meet quarterly. Work groups work on specific cancers.
You guys could disperse from the kitchen if you're done eating. That'd be awesome.
Hi, everyone. Just a reminder here, and I will go through, but if you are not speaking, if you could mute your line, that would be great, just so that we can keep to the flow of the meeting. I thank you in advance. Lynn, back to you.
Okay. The subcommittees provide subject matter expertise for the work groups and the PCC at large. Next slide, please. Okay, the subcommittees, as I alluded to earlier, interface with the work groups. As you can see there, communications informs the public of the PCC work. Also can be very helpful in your individual groups. Disparities engage work groups in health equity initiatives, a relatively newer group, and one that we should all be engaging with. Evaluation enhances PCC operations by updating members on the cancer plan goal achievement and reviewing program performance. Membership recruits and retains members, an area where we really all need to put on our thinking caps. Many of the committees may be in need of some new members, or there are some members that want to sort of do something else, which we all have the flexibility of doing, and some of the really the value of our organization that you can have different interests. And then policy works with legislation on key cancer initiatives. And the exciting thing here, a number of us did engage with Representative Gatos, who was on this morning's CAB meeting, and she chairs the Cancer Caucus, and she's very, very much interested in what we're doing and wants to engage with us and have routine meetings and presentations. And it's been a long time since this has happened, so we have a lot of things we can offer, and hopefully we can start to collaborate more closely with legislation. So this is really exciting. Next slide, please.
And I think
this is you, Kate, isn't it?
This is me, and thank you so much, Lynn.
Thank you.
I apologize for a little echoey today. And again, just a huge thank you to our speakers and those that are joining us from this morning to this afternoon, to all of the incredibly dedicated and hard work that you're doing each and every day, and bringing that to how we are moving forward as a coalition and changing the communities that are here in Pennsylvania. And so, in thinking about the sharing and the space for awareness, that was part of even just kind of revisiting some of that structure. And thank you, Lynn, for taking us through that. As you had heard from before, just, kind of understanding our goals, what the work really does kind of look like as far as its lead to the work that we are doing as part of this coalition. We are led by incredible folks who have taken on the chair role within each of these components that you did here. So I do want to take a couple of moments to recognize our co-chairs, and really kind of talk through and share some of the changes that we have even going into our 21 year. As this also brings some, as we had noted before, some changes and opportunities for others to move into those chair roles. So I'm going to kind of just, of course, do a shout out to those folks, and even a call out for some other opportunities here. So to kick us off, we have our communications team led by Lisa Lawrence and Jen Pensinger, and thank you for all that you do. Our disparities group with Chrissy Valania and Sharnita Zegler-Johnson. Evaluation, as you heard this morning, with Heather Bastone and Mark Matovich. Membership with David Bueno and a newer member, Casey Monroe. And policy led by Emma Watson and Ruth Mazaletsky. Oh, Ruth, I'm sorry, I butchered your name. So thank you for your work with our subcommittees. With our work groups, some changes here and just some recent changes that I just want to note as far as vacancies go, because our 21 year will look a little different. With our colorectal cancer work group, I want to thank our outgoing chairs, first and foremost, to Lynn Robertson and Laura Toole. This does leave some space for some folks who may have that interest. And so I'll just do that call out for if you do have the interest to let us know, and we'll kind of go from there. With genetics genomics, we have Andrea Durst and Alana Kolek-Ram. With HPV, with Pam Schauer and Joanne Sullivan-Schimpf. And with lung health, I want to thank our outgoing chair of Yvonne Cohenbaker, and thank Denise Whaler and Caitlin Cluck, who is our newest member there. To move forward with men's health, we also have some vacancies, but I do want to, of course, thank our outgoing chairs, Claudette and Jim Williams. And Jim, I know you're on the call. And survivorship, I want to thank our outgoing chairs, Diana Fox and Susan Jacobs, and welcome in our new chairs, Amy Jacobs and Stephanie Washburn. So again, thank you to all of you, to the work that you do, the leadership that you bring, and to the continued road and journey you will take us on within our space of 2021, hard to believe. So now I'm going to shift gears here to a little bit of a space of where we will open up and have some dialogue around our work groups. And so this is an opportunity to share how our coalition is moving forward along this cancer plan. And so what we've asked our work groups to do is prepare just a couple of key points to kind of lead us in highlighting and sharing what's going forward in this year. So they have a few minutes to share that. And what we will do per work group is then open up a few minutes of dialogue. So as Lynn had mentioned, you can hear some of different voices who maybe haven't had that opportunity on your various work breakouts that you have throughout the year, or just that how we can branch and move across our teams in that space. So to kick us off, I'm going to ask our HPV work group to lead us in this discussion. And so Joanne, I don't know if it's you that's leading this conversation or Pam, so I'll leave it to one of you to come off of mute.
Hi, Kate, this is Pam. I think
Hi,
Joanne,
Pam.
so I'm going to give her a second here to come off of mute. And if not, I can jump in for sure. Okay, I'll jump in. Kate, can you hear me?
I can.
Okay, great. In terms of the HPV work group, there's some great things happening. 2020 highlights right now, we're seeing just a great explosion in the work around dental and oral health partners in HPV education and screening. So we actually have a really large meeting coming up next the 7th, on December 7th, with our dental deans. We actually have the Pennsylvania Dental Association president going to be on our call, and a special presentation from Dr. Nicole Parkerson on oropharyngeal cancers. So this group is really exploding with a lot of work. So a highlight from 2020 has definitely been the growth of that group, that portion of our subgroup of our HPV work. And then the virtual provider education within some of our health systems has been outstanding. We had some movement with the UPMC, and I know Lynn, you're on. Lynn Robertson, you had helped with this, and you guys did some wonderful things in the Western area and reached lots and lots of practices associated with UPMC, and it was a fantastic online education opportunity, and they had 2 this year, but the second one just happened recently, and it was very good and reached a ton of offices. In terms of what the group is going to be doing in 2021 and 2022, we will continue to look for additional partnerships with our providers and stakeholders. At this point, we're really networking among some of our folks and saying who else needs to sit at the table. So that's been a big focus for our team, is working through each other to say, who else do we need to bring to the table? Next slide. And then moving ahead in terms of 2021, one of our greatest challenges for the HPV group has really been around data. And as we know, in Pennsylvania, we do not have a mandatory immunization, that's okay, a mandatory immunization registry. And we're hoping with COVID and some of the things happening right now that work to make the current system a little bit more stable and maybe have some more capabilities will be an exciting thing for our group moving forward in 2021. Wait for that slide to come back.
My apologies, Pam.
Oh, don't worry. Nope. I should know most of it off the top of my head.
My apologies. Sometimes the controls request, it can be very sensitive. So
yeah,
it just kind of had that little thing happen. So we'll get right back to this. My apologies.
No worries. And I'm impressed by, I mean, the slide deck has been wonderful all day. So thank you all for compiling it.
I think
so.
There we go.
There we go. And then just really right now, one of the other things besides that mandatory reporting, really looking at the hesitancy. As folks know, there's hesitancy right now for the COVID vaccine that we're hearing. And among our work group, that has become quite a discussion. Overall with vaccine hesitation is how to come back to the basics, let folks know that vaccines are safe, the systems that they go through and the processes are really, really rigorous. But we're seeing lots of that in terms of our group, and it's a big concern. So hesitancy in general with vaccination, not just HPV, as we go forward. And we know many folks have skipped going for well visits with their children, and they're starting to come back now. So those numbers are starting to bounce back. But those are some of our big things as we look ahead in 2021. Thanks, Kate.
Thank you, Pam. And so now what we would like to do is, you heard a little bit of a taste of what's going on in our HPV work group, is really allow for this time together to talk through, ask questions, give any sort of thoughts. So we would like to spend a couple minutes, if you will, just allowing for that dialogue. And so I'll encourage folks to come off of mute to share anything or ask any questions that you have.
Pam, this is Lynn. I have a couple comments or questions. Do you think there might be an opportunity for the policy subcommittee to actually collaborate with this group in order to help potentially work with the reporting of the data and maybe get some things in place along those lines?
Yeah, definitely, Lynn. And I know we've spoke, I think, and shared some things over with the policy group. We thought initially with getting some things in terms of the data efforts that we would, try to reach out and see what was going on. But one of the most recent things has been a letter that just went from Heather Enteman from Merck, actually sits on our group as well. And they actually were able to bring all together all kinds of health system stakeholders in the state of Pennsylvania, and they have sent and drafted a letter. I've not seen the final copy. We saw the draft copy with all the signed on folks. There was tons and tons of health partners and organizations that signed on, and the letter is going to go to Dr. Levine and Governor Wolf, and it talks about, the urgency of vaccines being lower and, just the need that we want to be partners together. So I know that letter was drafted as an effort to kind of, again, get in that policy arena to say we need you, and there's a real urgency here.
Great. And I just also wanted to mention that in regards to your vaccine hesitancy, my recent funding is actually dealing with a collaboration with some Twitter gurus, and we are actually working with Twitter related data and looking at HPV vaccine hesitancy and potentially anti-vacciners, but we're not so sure how far we're going to go with that. But we're also engaging cervical cancer advocacy groups across the country and also doing some parent focus groups. So once we get moving in that direction, and our whole goal is to really come up with ways that we can help get a more positive message out there and hopefully increase vaccine use, not just HPV, but across vaccines in general. So that may be something of value depending upon how it comes out to share with the group.
Oh, that would be great, Lynn. And I know Amy Leader out of Philadelphia has also been, I think, working on some research around social media and tweets and things associated with vaccination. So, well, that's great. That'll be awesome in 2021.
This is Lisa Davis from the Office of Rural Health. So thanks for all of this. This is really interesting information. I just wanted to follow up and talk a little bit about the COVID and flu vaccinations that are going to be required. All hospitals are now required to submit data to CMS once a week on their vaccination rates. And there's tremendous pressure to submit those data and to be at 100%, or else they risk being fined. So I do want to say that I think COVID, just as it has taken all of the oxygen out of the room in general, is also going to be something that the hospitals and the healthcare providers are going to be very focused on, as well as influenza vaccination. So I hope that HPV can get in there and be part of that, but I do want to say it's probably going to be overshadowed for the next few months by COVID and influenza. I also wanted to say that the Hospital Association, which has a provider coalition that they've organized, and I think there are a number of folks on this call who are also part of that initiative, the Hospital Association has developed a toolkit for hospitals and other providers that might be of interest to the group. And there could be a way, now that's focused mostly on influenza and COVID vaccination, but obviously it could be translated and transferred over to HPV.
Great. Thank you for sharing that, Lisa.
Any other comments, questions, thoughts to engage with our HPV team?
And Kate, just a shout out to everybody who's on that group. I have to say it's probably one of the most dynamic and active groups I've ever had the pleasure of helping to co-chair, and I just think our stakeholders in this group are just outstanding.
Pam, before you get off, one other I guess it's a question. You know, we do see oral head and neck cancers increasing. And although I don't have all Nathan's data in front of me to be sure just how much, and we see it particularly in younger males. I mean, this might be an area where we also need to focus on. I know we talk a lot about it when we talk with the dentists and when we talk in general about HPV, but maybe it's an opportunity to focus on males in particular in regards to HPV and cancer.
It's good feedback, Lynn. Yep. Very good feedback.
Thank you so much. And even just as we transition from our first work group to the next, in thinking about some of the themes as we sort of talked about that kind of cross-cutting opportunity and sort of some of those umbrella focuses, as you heard from this morning, you know, membership is going to be something that we are really continuously looking at. So that is even just something on all of our minds and thinking about this work. And if there's opportunity to fill some of that space within kind of our, not only our membership goal, but even some of the needs within our work groups as we move into 2021. And, you know, that's sort of the same thing as we'll kind of hear a little bit about even just some of those other overarching opportunities after the work group presentation. So just some food for thought as we're dialoguing or thinking that there are some of those things that are on our minds that will continue to press forward. So again, thank you, Pam. And now I am going to turn it to our colorectal cancer work group. So Laura, are you coming off to talk a little bit about this?
Yes, Kate, thank you so much. This is Laura. Hello, everyone. It's good to be in this meeting virtually. So yes, in terms of our colorectal cancer work group, when we met briefly to talk about 2020, a highlight that we did identify was that although initially, you know, in March, which ironically is Colon Cancer Awareness Month, when things shut down halfway through March, that despite that initial shutdown, that large-scale colorectal cancer screening programs and initiatives across the state really rebounded nicely and rather quickly following the early days of the shutdown. And now across the state, I'm happy to say, are all fully operational and on target to meet program numbers for completed colorectal cancer screenings in 2020. And the groups across the state that are involved in those types of initiatives really identified that, you know, immediately upon the shutdown that we all reached out to our partners, many of whom are federally qualified healthcare centers or free and sliding fee scale clinics, to communicate with them that while temporarily we weren't going to be encouraging people to go out and get preventative colon cancer screening because of COVID, but we maintained communication with them to identify once things opened up that we were up and running again. We maintained communication with our other healthcare providers and importantly with screening sites so that when we were reaching out to patients to talk about colon cancer screening, we could talk about if they were talking about colonoscopies, you know, what some of the COVID protocols may be. And then certainly for some of the at-home tests, making sure that patients had appropriate education about how to complete those tests. And then in terms of what our work group is looking forward to in the next coming year or two, you know, again, in light of COVID, it's not going to go away anytime soon, to really look at ways to further promote that at-home screening modalities for colon cancer. Many on the colon cancer work group reference that patients are preferring this. There is some reluctance, if we're talking about colonoscopy, to have to go on site for that colon cancer screening. Some of those colon cancer screening, colorectal or colonoscopy facilities rather, do require COVID tests, and there are appropriate precautions, and we are able to provide education to patients that are going to have that particular modality. And some on the call were also doing some research into this, into that patient preference and how we can maybe increase that at-home screening where some patients for. And then the other important thing that we talked about on our recent subgroup call was that primary care practices are really overwhelmed at this point because of COVID in a variety of ways, both personally and professionally. That of course that they have an increase in the number of patients that are being seen for COVID-related issues, that staffing resources are really focused on almost crisis intervention, if you will, at this point, and maybe shifting away from preventative cancer screenings, including colon cancer. And really also on a personal level, that these are human beings working there, that some of them are directly affected by COVID and the ancillary impact of COVID in terms of if they've got young children at home, so that staffing in some of these primary care provider sites across the state, staffing is low, but the volume is higher. So really looking at how can we support what can we do as a coalition to help support primary care practices. The next slide talks a little bit about more ways about that. So, one of the things that we talked about looking at in terms of that challenge is exploring what may work in terms of addressing that issue, exploring ways to effectively engage various constituencies, whether it be health systems and health plans, to develop and implement ways to provide that type of support to ensure that preventative cancer screenings continue to be addressed in their patient population. So one of the examples was bringing together healthcare plans and health systems and other stakeholders to collaborate on these types of issues. And then in terms of group discussion, what would be helpful moving forward is, we don't need to reinvent the wheel. If there are existing models out there where there was some success, or if there's a best practice or best practices regarding, the above, we'd welcome the opportunity to speak more about that. Thank you.
Thank you, Laura. So at this point, if there are, thoughts or even just that call out for existing models, that would be helpful to begin our discussion.
Hi, this is Sharnita. I'm actually curious about one of your last statements about bringing together various healthcare plans and health systems to collaborate on these issues. I know that happens on occasion, but it hasn't been very successful in the past. Do you have some insight into how to make that happen?
No, we're actually looking for that insight.
Okay.
It was commented on the call by various members of the colon subgroup, is that while there has been some success with that in the past, it's been, I think, as one person commented, it's been largely a piecemeal effort, and piecemeal efforts lead to piecemeal results, and that has been a big challenge, probably increasingly so in terms of healthcare plans and health systems in terms of collaborating. So what we were looking for is if anyone out there, whether it's related to screening or the model itself that we can apply to this particular issue, we'd welcome what that might look like.
This is Lynn. Also during our conversation, we did discuss this in a little more detail. And I think it was Ron Myers who actually really brought this forward and thinks this is a direction we really should work on. And most of us don't, pardon me?
No, I said that's correct. It was Ron.
Okay. Yes. Most of us that are in large healthcare systems, and in particular, I'm in one that also has an insurance product. And even though I collaborate very frequently with that healthcare plan, we all have our goals and we all have our initiatives, and people have to report to different agencies, etc. but it still seems that we don't collaborate together, and it is quite challenging. I don't quite know if it's because, you know, who gets the credit or who wants the credit, etc. But there's still so much work to be done. And as simple as it is, even with electronic medical records, that you get, you know, alerted that your patient needs to be screened for colorectal cancer, there's ways around that. And then even the healthcare system and how they do things and sending out reminders, etc. They don't work in collaboration with the healthcare system. So I think there's a lot of work to be done there, but we don't have easy answers. And I think it's going to take actually bringing people to the table and hopefully start to work through some of these barriers.
Lynn, hi, this is April. Hey, I'm not sure if you're aware of a resource, but the National Colorectal Cancer Roundtable released a little bit back colorectal cancer screening at communities and face and respond to the COVID-19 pandemic. So it's a resource that's been published since that discusses how to make colorectal cancer screening still a public health priority and how you can provide to move safely with screening in lieu of COVID-19. So maybe that's something that we could share more readily.
Yeah, I think that's a good idea, April. It is a good resource. You know, interesting, I don't have any trouble getting patients to come in or doing any of the screenings, be it colonoscopies or the FIT testing. But I think there is still hesitancy, you know, among some individuals out there, et cetera. But it takes a lot of talking and a little bit more hand-holding, just because, you know, their concerns are legitimate. So that would be an excellent reference for us to share with everyone. And I think, again, we need to do, you know, get the healthcare systems and the healthcare plans together and see how we can even make further efforts going forward. Other
Lynn,
thoughts? Yes.
This is Cindy Newmeyer. Can you hear me?
Yeah, I can hear you.
Hey, Lynn, I just wanted to comment that I think it is happening. I just don't think that it's the areas that you might think are doing the collaboration, because we meet with our providers from health systems, including ones, that Ron Myers is a part of, and we are working with them on increasing these rates because it's part of their quality programs, but I just don't think it's the area that he might be in. So it's the quality departments in these health systems that we're working with. So I'm not sure if that just entitles making sure the right people are at the table versus, reinventing the wheel, I guess.
Great, thanks. Anybody else? Laura or anyone, is this an area possibly where, I know it's definitely an area we need disparity to be considering that, but also what about policy? Is there anything along the lines of policy in colorectal cancer? I know generally, you can get screened, but I know in the past there were some issues if somebody had a positive FIT test, that was looked upon as the screen, and then, their next step, if they had a colonoscopy, was looked upon as diagnostic, and sometimes there were problems with coverage. I've not heard that from anybody recently.
Yeah, I will say in our patient population, we have not, we don't necessarily deal with that because of the type of funding we have. We're able to help pay for that if someone doesn't have coverage for that, for the diagnostic piece.
And see, we're the same way in my program, but it may be an area that we, or the committee should, at least evaluate or look into.
I agree. Yes.
Lynn, this is April. And I don't know if anybody from ACS CAN is on the meeting, but I know a year or two ago, this is at the ACS CAN level.
Yeah.
And I don't know if Maggie's on because I know there had been a bill or something that keeps getting stalled where they were trying to get that through this legislature.
Hi,
But maybe we can reach out and
this is Emma Watson. I'm with ACS CAN, and you're correct. We are working on this at the federal level. We have a bill that addresses
Okay.
cost sharing during colonoscopy. It's something that's been a priority for a number of years, and you're right, we had seen some forward progress and then it had stalled. It will continue to be a priority for us moving forward, and I can certainly send out some information on that, especially when we get into the new session, so that everyone has that update.
Great. Thank you, Emma.
Sure.
Thank you. It's a great discussion. And thank you, Laura, for leading us in that information with the work group. And we'll continue to press forward. It looks like we have some good thoughts and ideas on how we can do that together.
Yes, much appreciation to everyone. Thanks very much.
Thank you, Laura. All right, next we're going to transition to lung health. And so Denise, I have you ready to go to take us through this.
Yes, thank you. Our highlight that we spoke about, we want to mention is the Citizens for Radioactive Radon Reduction. That's the CR3, worked with the American Lung Association and also DEP. They developed, printed, and we distributed approximately, it was about 10 to 12,000 radon calendars. They were education calendars that went out across the state. A lot of the partners in the work group assisted with the distribution. To name a few, we have UPMC, Erie County Health Department, Highmark, and Health Promotion Council. Jackie Nixon, it was her idea and she pretty much headed the whole thing. She received positive feedback from 4 different organizations. I don't even think I have them on the slide there. Some out of the Pittsburgh area. Protect PT is an environmental citizens group, and GAS, which is a group against smog and pollution. Also, Women for a Healthy Environment distributed calendars, radon calendars, through their Healthy Schools program. We wanted to highlight that. It was an excellent example of a lot of collaborative work. And I give a good thumbs up to Jackie Nixon. She did excellent marketing with that project. When we're looking at what is our work group doing for 2021-22, I sort of shortened our 3 strategies there. The first 2 we have worked on, and we're going to continue to work on linking tobacco cessation with radon education. We want to kind of tie the 2 together. And the RPCs have been doing a good job with that. Couple of the contractors have taken on some radon test kits and literature to help distribute that to their clients. Others are referencing their clients to the website, the radon website on DEP. And we're also working on year-round radon awareness. And this calendar that we spoke about, that was a big help with that. And the third strategy that we've sort of emphasized a little more for the upcoming year is I wrote all things lung cancer screening. I could specifically read our goal here is to identify and promote lung cancer screening education activities, resources, and tools to smoking cessation providers and lung health stakeholders throughout Pennsylvania to raise awareness and increase referrals and access to lung cancer screening services for eligible individuals in need. And a short example for that is UPMC lung cancer screening program is looking to have mobile CAT scan units in some of the low income areas. That's something we're looking to do in the upcoming year, and that would help address some of the health equity issues. Guess we want to move on to the next slide. So moving ahead in 2021, COVID, of course, has been a challenge. A lot of the staff working efforts, their priority are for the COVID patients. We also see some social distancing challenges along with the lack of technology in these low income areas. A couple things that have been done in the work group. Nate Burton with the PA Arts Association and his MOVES project That, of course, was stalled because of COVID. They were doing outreach right in the community. So they were to address the health equity, try to get the information to the community. They were doing the outreach in community churches, barbershops, going right in to those areas. But when COVID hit, then they don't want people coming in, mixing like that. And if they don't have the technology to view virtual meetings, that's been a problem. So that's an area that's been a challenge. And for our group discussions on moving forward, funding and access for lung cancer screening for low-income community has been an issue. We also are discussing policy, the need to get some policy in place for radon testing and funding for mitigation. That's almost always been an issue. We, insist that you test for radon, and then the problem is, well, if it's high, there's no funding to help with mitigation installations. And the last thing I want to mention is we've been keeping up with our monthly calls. One thing we all feel is very important is to keep the open discussions on the unknown and just simply continue to have calls and communications.
Fantastic, thank you. And so I'll call upon the work group, or excuse me, the coalition for thoughts, ideas, and to generate some discussion around what Denise has shared.
Denise, also to share with you, this is Lynn. As of January 2021, on behalf of two of our physicians, a pulmonologist and an oncologist, they actually have a fund that they have put together, and we will be able to provide for those that are uninsured or underinsured free lung cancer low-dose CT screening. Now, it will be on site, and that would be at the Hillman Cancer Center, but we also can help with transportation if necessary. So we are really, and a lot of what I do is actually reach out to these low income groups and disparate populations in order to educate them and get them screened, and working with a lot of the local federally qualified health centers and our free clinics. And we've already done education in those areas so that they're ready and can start to refer patients in January.
Excellent. Thanks for bringing that up, Lynn. Also, Dr. Ron Myers with Thomas Jefferson University, he was working with his team on a lung cancer screening training tool. Lynn, you might be more aware of some more of the detail or the progress of that. The last we discussed, he's working on the white paper.
Oh, wow. No, I'm not aware of it. I'd be interested in learning more about it.
So it was like a multi-level approach to, let's see, I'm looking at some of my notes here, achieve goals by, it was to support the primary care physician. I believe there was going to be a care coordinator that would reach out to the patients and do some preliminary work so that when they could get into the doctor's office, they'd be already interested in the lung cancer screening. Yeah, we'll have to, like I said, I know the latest note I have here is that Ron was finishing up the white paper, and hopefully we'll have that out soon and we'll have more details on it.
Oh, great. Thank you very much.
Yeah.
Hi, Lynn. This is Brenda. Yeah, I have suggested once that I'm on the steering committee with Ron Myers for regarding this paper, and once it has been published, then I think we're going to try to share that with this group. He's been willing to do that, and I think it'll be a worthwhile presentation.
Great. Thank you.
Yeah. Thanks, Brenda, for connecting the dots there.
It's fantastic stuff going on. Other thoughts, questions, things to share regarding lung health?
This is Sharnita. I have a question. Regarding trying to just get some more funding for mitigation and radon testing, has the coalition ever made a concerted effort to apply for private funding or government funding to do these sorts of activities?
I know I've been familiar with Nate Burton and his Moves project, and his pilot was, the premise behind it was he had approached different companies, fan manufacturers, radon testers and mitigators in the industry, and was getting things donated. So I'm with DEP, and we have access, we get surge grant money, state indoor radon grant money through EPA, and we can use that for all kinds of outreach, education, purchasing radon test kits, but you cannot use that funding for mitigation installations. So as far as funding goes, that's the grant that we use for the work that we do through DEP. On the national level, when homeowners call us and ask if there's assistance for installation, the USDA website has some grant money for home improvements. I believe the applicant has to be over 60 or 62 years old, and they also have to show low income, and we'll hand that information out that's more for specific homeowners. But I'm not aware of other grants or funding that have been applied specifically for testing or mitigation.
This is Lisa Davis. One place that we refer folks to regularly to get information on funding is an organization called the Rural Health Information Hub. They're funded by the federal government to be the one-stop shop on all information related to rural, but they also have information that's useful for non-rural issues. And one of those is a very robust database on funding. So if you look at the Rural Health Information Hub website, they have a ton of information on there, and you can do a search for funding for lung health or anything related to that, radon testing and so on, safe homes. Or there's an 800 number there, and you can call, and they'll do a free customized search for you.
Wow, that's great, Lisa. Thanks.
Very good. Thanks. You say that's the Rural Health Information website.
Hub. It's yeah. All you have to do is just type in RHI Hub, and it will come up.
Thank you.
And I can tell you, if you tell them that your state office of rural health referred you to them, you get to the top of the queue. But they're really quick anyway, so it doesn't really make much difference.
Okay.
That is great. Thank you, Lisa. What a good resource. Really good dialogue. And I think this is exactly, what we're envisioning, just kind of that across the aisle sharing and the questions and sort of seeing where we might have some of that opportunity. So thank you for this continued discussion. To move forward, we're going to switch to our survivorship group. And so, Amy, I believe you are going to be our speaker on behalf of the group.
Hi, yes. Can you hear me, Kate?
Absolutely. Thank you.
Okay, great. So kind of the same theme with the previous groups that have gone. I'll start with our highlight here. We're going to make sure that those who are living with or beyond cancer have access to care and resources for people, especially relating to screenings, because like, some other people have said, I know a bunch of cancer survivors out there that still need to get their yearly screenings or what have you. are concerned with going into doctors' offices with COVID. So ensuring that any barriers they might be facing, whether it's now that funds are limited and travel is an issue, anything like that, we're addressing as a group and making sure that they have access to get what they need at this time, whether that's also access to food, etc. With that being said, there is going to be a new Live Strong at the Y virtual class session beginning here in mid-December. So that was something that we created over a couple of months, taking our in-person programming and making it a virtual capacity type program by removing any barriers. So really seeing how we could do something from a program that was housed in a wellness center to having it available for people in their home, but not requiring them to have any access to, hand dumbbells or anything like that. So making sure that it adheres and it's accessible for everyone, regardless of maybe income level involved or anything like that. Also, for the work group then moving into 2021 and 2022, we, as some others, are hoping to expand our work group membership to encompass the range of disciplines, health systems, and advocacy organizations. So primarily, we're going to be reviewing our list as our group. And one of the main areas that we saw room for improvement is to recruit an individual living with cancer. We have some ideas, Stephanie and I talked, and then we're gonna, play it to the group and see what we can come up with there. But we feel like that's a vital part to our expansion with our work group. And then we want to make sure that we're proactively assessing the needs of individuals living with and beyond cancer, as well as incorporating health equity into all initiatives developed. Definitely looking at, any and all disparities and how it affects different groups out there as survivors. If you want to move to the next slide, Kate. So that same common theme, we want to make sure that we're eliminating any and all barriers to care experienced by the cancer community amidst the pandemic. There were a lot of barriers prior to COVID, and now a lot of focus has had to shift possibly to make sure that, any new or transformed barriers, we're addressing those as needed. And then we want to make sure that we're adding new members to the work group given the extreme demands placed on healthcare providers at this time. So keeping that in mind, who's going to be available to attend our work group discussions. So as far as needs or what would be helpful moving forward, we definitely would like to see some assistance from the PCC committees in promoting community awareness of available resources. So that goes in terms of anything that a cancer survivor might need access to or should be aware of, just being able to promote that, whether it's through social or any kind of avenue that would reach that community. And then any updates on policy changes that impact the cancer community. So there's tons of things always being updated and changed, as we saw with, Pat and their great strides with the breast cancer coalition. So that's great, but just areas kind of like that. And then referrals of potential quality of life work group members. So if anyone knows of someone that would be a good fit, to definitely communicate that to us so we can get them involved.
Thank you, Amy. And same, we're going to open it up to the group for some thoughts, some discussion related to the content that was just shared, and certainly the kind of call out for any assistance that we can provide as a coalition. Amy, I think, your points around just really that building out the membership of the work group in particular seems like that is a space that's really going to be a great catapult to these movements that have been identified for 21 and beyond.
Definitely.
All right, well, thank you. All right. So we'll move forward to genetics, genomics. And just with the content that is in here, I'll speak to this. And then if there are members of this work group that are on, please feel free to come off of mute and share anything else, or we can even, as a group for kind of purposes, as this call is recorded, have any dialogue that might support their information that's provided here. So similar to the theme that was shared from the last meeting in September, some of really where the focus is that the genetics genomics group is focused on are really developing those patient and provider online toolkits to really, address some of those things that we're seeing in the space of disparities and access when it does come to genetic services. And really, one of the things that they are planning to work on is that, kind of that gathering of information to really, understand and plan and move forward accordingly. So that survey of providers and the public in our state of Pennsylvania. So some really good things that we can look forward to from this work group. But I'll open it up to dialogue from this coalition to see if there's any questions that you may have, or even just thoughts that we can share. Or again, if there's any of our members of this work group that are on that would like to also chime in, that is also great.
Kate, this is Lynn. I'm just wondering again here if there is an area or a need for any policy related work. I'm not as familiar. I know there used to be a lot of issues in regards to genetic testing and coverage, but I think some of that has changed some, but I'm not quite sure. But there might be a role for interaction there, as well as I'm glad to see that they're also addressing the disparities to access.
I think that's a great point, Lynn. And I think that's a great question that we can kind of pose as part of this to that work group to see just what discussions are out there, or even just where we can intertwine with our subcommittees for how we can support this work moving ahead. It's a great point.
This is Sharnita, and I think just related to what was just said, has this group already determined what the disparities are, where they exist, and what the causes are?
Sharnita, this is Lynn. I mean, I was a little involved with them early on, and I don't think so. Unless something has changed drastically, I do not think so at all, and that's a very good point.
I'm jotting that down too, because I think again, same sort of theme throughout. The generation of good questions and dialogue really helps us to collaborate and cross-sect a lot of this important work. Great question.
Okay, while you're on it, the other thing I see as an issue, and it comes up in my work all the time out in the community, is lay individuals or people, even, I do have a nursing background, but genetics is not my strength necessarily. But people ask a lot of questions about genetic testing, particularly if they've had cancer or cancers in their family. And there might be a role here to actually work with individuals so that they feel comfortable talking to, groups or their peers or their neighbors or whoever, even, healthcare providers about genetic testing. It doesn't have to be that you have in-depth knowledge, but that you can have a, good conversation with them and offer them some direction.
Absolutely. And I think about some of that current work that this team is doing around the development of those toolkits, and just really understanding a little bit more about them, I think would really kind of help some of even the questions that we're asking here, and just even some of the supports that we can provide moving forward as far as even feedback or target audience or what have you. I think that's a great point.
Hi, this is April. Yes, because I work with the DG committee pretty closely. The provider toolkit is almost near completion and ready to go to be reviewed. And there's been a lot of hard work done on it over the last year. And that is one of the goals, to be able to give healthcare professionals the resources and tools that they need to speak to patients, to educate themselves on what is genetic and genomic testing at the different levels. Like if you're a PCP, how do you coordinate? So those are some of the things that when the provider toolkit is available, will include for healthcare professionals.
Great, thanks, April.
Fantastic. Well, thank you. We're going to move forward to our final work group that we're going to be sharing and dialoguing on today, and that is our men's health. And so, Sharon, I know that you put together some of this information, and I know, Jim, you're here. I'm hoping still here. Sharon, if I could call on you maybe to kind of walk us through some of this great content.
Okay, Jim, if you want to jump in, just feel free to jump in. Some of the things has done over the past year is, first of all, developed a recruitment list of community-based organizations. And I have Jim to thank for providing that to us. That's going to be helpful because, again, in dealing with men's health, we heard it this morning. We've talked about it before. This cannot be done at a high state level. It has to be done at a community-based organization group too. So, and we've addressed a lot with prostate. That's how the whole men's health group came together in the first place, was to address prostate cancer. But if you look at the group that we're trying to deal with, that we'll call it middle-aged men. When you get my age, 45, 50, that's middle age. But so we're broadening the scope to be not just prostate cancers, but to also look at colorectal cancer and lung. And that leads into the next bullet that we want to work with Sharnita and Chrissy and the disparities subcommittee to identify areas and population centers of need. I'll skip the next bullet and go on to the last one there. I know that Jim and a group worked very hard to put together a funding proposal to send to the legislature. I was involved in that a little bit with Jim. And it's just right now getting funding for something new is just not in the cards. We all know this has been a very difficult budget year for us. We don't know what's going to happen in 2021. But with everything happening, I think, around Black Lives Matters and starting to look at the need of minority, especially the minority man, I think there's a possibility. And I purposely skipped the bullet right ahead of that is because a few months ago, CDC came to me and said, hey, do you want to present nationwide on all the things you're doing around men's health? Because a lot of other states haven't really started to tackle this. And if Jim wants to pipe in, he can talk about it too, because even from the Prostate Cancer Coalition, he's always out there looking for, talking to other stakeholders, other partners to find out what they're doing. And they can't really help because Pennsylvania seems to be ahead in terms of some of the things that we're trying to do with men's health. Thus, the presentation we had this morning in trying to engage the Governor's Commission on African American Affairs. I asked David from the membership, he knew her, so to go to her and, pretty much make that connection for us, because maybe this is another way we can get some voice into the governor's office or something and broaden what the commission is doing to address more around men's health. Jim, anything you want to add here?
Thank you. Can you hear me?
I can hear you.
First of all, I want to, on behalf of Pennsylvania Prostate Cancer Coalition and the Men's Work Group, to thank Sharon and her efforts and our efforts to bring awareness to men's health. She's been an outstanding champion for us. And also, although we many times are becking at her to give us more and more support, she's done her best to support us. And as she goes out in retirement, we just want to say thank you, Sharon, for all you've done.
It's been a pleasure.
Secondly, the following comments are going to be made based on my going out as the chairperson, but a 20-year tenure with a member of the CAB. I've been a member of the Prostate Cancer Task Force, a member of the Cancer Planning Development Committees, and the chair and co-chair of Men's Work Group. Sharon has mentioned about maybe expanding the focus in men's health. Initially, our focus was on prostate cancer. We kind of modified that to prostate health. But as you know better than I do, the patients have comorbidity problems. In other words, on any given day, prostate health or prostate awareness might be the least of their medical concerns besides the other social and economic concerns they have. So I think as a general statement in the cancer world, we need to do more focus on the whole patient, not just on specific organs that we might be interested in. I realize this is not an easy accomplishment, and I also realize that our healthcare system isn't really set up, although we're going that way, to look at the whole person. As you get older, you realize that you must go to this specialist and that specialist and another specialist to be totally treated, and you hope there is some coordination among the specialists. But I say all that to say that maybe, as has been presented earlier, we need to expand men's health to include emphasis more than just prostate cancer, but maybe colorectal cancer and maybe some other areas to maybe bring more focus and more assets into that work group. I said I am going out as a chair, but we need to bring new leadership in. I've been in this business with the Department of Health for 20 years, and I think that new younger membership with new energy might bring some more stimulus to the Health Committee. And in that regard, we have submitted a list of potential chairpersons for the committee, and also some organizations that we look at to get additional support. As a minority, I find that many times when we look into the community for support, we focus on the barber shops and the beauty salons and the churches. But there's a diverse group of minority, both male and female organizations out there. And I submitted to the Department of Health a partial list of other agencies that we might also tap into for not only men's health, but for the other work that the coalition is doing. As has been mentioned in the past, we think in many cases women are a better source to deal with reference men's health than men themselves. Good example is how many men are on this call today? And as I travel around and deal with men's health and health issues in general, there's very few men that are there with me. And so we realize that women have a tremendous influence on their families and on the health of their families. And so we suggest that there be a stronger focus in that area. And as I said, we submitted a list of other organizations to include the Chamber of Health, the various sororities, fraternal organizations, and other activities within the minority communities who are providing services to that community and might be of assistance in not only men's health, but also to the other committees. The elephants that have been in the room that I've tried to tackle for the 20 years are still there. And we bite at them, but we haven't been really good in overcoming these elephants. One, the first elephant is when you're dealing with men's health, you're dealing with men. Men don't advocate for their health as women do for their health. And so as a patient advocate myself, when I go in to talk to a decision maker about the importance of men's health, I don't have 100 men behind me supporting that effort, as my friend Pat does when she talks about breast cancer. So in many cases, men are the ones who are making the decisions on funding and on policies, etc. Yet they don't bring their own health as a hard priority. So we have to find a better way to market men's health. I suggest that we look out of the box when we do that. I suggest if you look at Pennsylvania Prostate Cancer Coalition website, and I will put that in the chat box, but it's www.prostatecancer.org. We try to start a conversation with men about men's health, and we have to do that in non-conventional ways, such as don't fear the finger, such as going to men's baseball games and hockey matches and Friday night happy hours and places where men assemble and try to talk to men about their health. As you can imagine, as many have said today, because of COVID, we're not able to go face-to-face, one-on-one with our target audiences. And yet this is the most persuasive, the best way of trying to get the message across. And it's very labor intensive. And so Pennsylvania Prostate Cancer Coalition have now spent some money with coming up with some videos, some virtual platforms to try to fill in the gap during this COVID period. And I suggest you go to our website and look at what we're doing. And as I said, we'll put that in the chat box. But men, it's just a different breed of animal. We got to find some ways to market this. We spend a lot of money on hard science, and it's very, very important that we do that. But I think we need to bring the soft science, behavior sciences to the board, the commercial market people, cause-related marketing, some of this out-of-the-box marketing to trying to get our message across in men's health and other health issues. And that brings me to my next point. The second elephant in the room is our healthcare system. And as many of you know, we don't have a healthcare system, we have a sick care system. And it's a system that, because of its fee-for-service provisions, causes the health professional to deal with quantity, not with quality. And although we're trying to improve that, and we have seen improvements, the healthcare professional is paid for the numbers, not paid for the quality. And we need to put more incentives into that program so that they are rewarded for the health of the population they treat, not the number and the diagnosis that we treat. So this reactive healthcare system has a great effect on the general population that we deal with, and as we discussed earlier today. They have a lot on their plate, as we've discussed. And so our issue does not have a high priority. You look at TV and you'll see loads and loads and loads of advertisements about taking the red pill and taking the blue pill and asking your doctor about this and asking your doctor about that. And in most cases, this is reactive medicine because this is what we support in America. In my travels around the world, I've seen nations where they spend a lot of money in trying to improve the behavior of health in the citizens. For instance, when we were stationed in Germany, a lot of folks marches were conducted, trying to get families out into the local neighborhood and into the parks and recreation areas. And we don't see that in America. We see us building more hospitals and more care facilities, but we don't see us building parks and walking paths and exercise facilities.
Jim?
Yes.
Thank you. If it's possible, just for the interest of time, if we could, even if others on the group would like to kind of give any thoughts or ask any questions, if we could allow for that at this point, that would be wonderful.
I'll stop and we're open for questions.
Thank you.
Any comments? Thank you.
To the coalition, any comments or thoughts, or just in kind of the movement forward and hearing the tremendous points and ways of moving forward that Jim and Sharon have shared. Anything to add to that or questions to ask?
Kate, if I can just add in terms of some of the things that we plan to do to move forward in 2021, the bullets are there, but it's really about increasing awareness. Again, getting the word out, expanding our reach. What other organizations can we bring into the coalition who will help us with, one, communicating what we're trying to get across and providing us the expertise in terms of reaching those hard to reach populations, i.e. men. And then I think in terms of messaging, it has to be careful measuring and careful messaging that has measurement in terms of, is it being successful or not? And in doing some of those things also, I think we need to try to increase our working with foundations and corporate engagement. So maybe through business coalitions, et cetera, groups like that, we can make some progress.
Great points, and really important points made about the movement forward for this work group and even just where we could have tremendous impact. I thank you for sharing that, and I'll just do a final call out for any other points or questions that the coalition may have to this team.
Kate, it's Lynn. I think we just need to say thank you to Jim and his co-chair also, who for all the tremendous work they have done and for all Sharon's efforts also. I think this group has really moved forward over time. Yes, there's still a lot of barriers, etc. It's a difficult area. And sometimes with the difficult areas, I know what we did with women early on, and with other topics, sometimes cancer is just too hard to discuss. So maybe we need to approach it with a different twist. Let's talk about diabetes or cardiovascular risks and then tie in the cancer. Just a thought.
Absolutely, and a great point, and thank you. And I think even moving forward as we sort of transition from our work groups to just some very brief even kind of call outs to the tremendous work and the support that our subcommittees can provide across the work groups. And I know there's a lot of cross-cutting work that is happening, but as you have heard even from the morning and even through this afternoon, that there's a lot of different ways in which our subcommittees are either being called upon or are hoping to be called upon in order to help us all move forward. So with the Disparities Subcommittee led by Sharnita and Chrissy, you know, they've been doing such a tremendous job really making kind of across the board, what does health equity mean here in the space of our coalition and the work and the plan that we have put together, and looking at those inequalities all throughout our state. And then you heard this morning a little bit of, you know, some of the progress about the video development that is in the works that came from the conversation, that really healthy conversation last time during our annual meeting, and how that's really getting us thinking in new ways as we move through 2020 and into 2021. So again, I really want to thank our Disparities Subcommittee, and I'm hoping for to Sharnita and Chrissy, you know, hearing some of that dialogue from our work groups, that there's some different things that we're thinking. I wrote down a couple of things myself when it does come to the work that you're doing or hoping to do. So I'll just kind of, you know, if you two have anything that you would like to share in addition to that.
Thanks, Kate. I think it's pretty obvious that there is some room for us to move in. I heard some call out for the colon group and perhaps the genetics group. We're always very glad to be involved. And of course, I'm always very appreciative of Sharnita's work with the men's health work group and the work that's being done across the state. We had such a great conversation in the last quarterly meeting and are just so thrilled about the ability to talk more about health inequity and how little really is specifically shown about Pennsylvania. So we're so excited about this video development. We have come back together again as a group, and we have tightened up a list of folks who are working on our subcommittee. And if there's anyone there who is interested in the cross-cutting work of the Disparities Subcommittee, we all know that the work we do includes those who are frequently not given the same opportunities. And if you'd like to participate in that, please let me or Shanita know.
Thank you, Chrissy. And sort of on that same theme that we've kind of heard, just the work that we have in front of us to address the various disparities that we are seeing across our state and in our communities. The sort of same holds to policy. We've heard that being kind of called out a couple of times. And so we have Emma and Ruth who are, really there for us, and also same thing, kind of jotting down even some other opportunity or things to look into when it does come to policy. One of the things to really share here is, and as mentioned earlier, Lynn mentioned this, and you may have seen her name in the participant list early in our CAB meeting, but that's Representative Gatos, she's based out of Allegheny County, but she is the chair of our state cancer caucus. And we've had some dialogue with her and her some of her team, and really looking forward to how we can be, as a coalition, guiding and working together with our Cancer Caucus. So Ruth or Emma, anything else that you would like to add here?
Hi, this is Ruth. Absolutely, we caught some opportunities for places for collaboration or some work with policy. And you brought up the point about Representative Gatos. We have her ear and the Cancer Caucus's ear. And I think, when there are opportunities, or if any working group recognizes an opportunity for some policy or potential policy action, to please reach out to us or join our monthly conversations. We are keeping those to a half an hour once a month and hitting upon the highlights of our progress. And so we're trying to make it easy for people to participate with our subcommittee that way. So feel free to join us or send us an email if you want to participate as well. The more the merrier.
Thank you, Ruth. And I think, just where we've heard all of this really good dialogue and conversation, there's definitely kind of across the board things that we can kind of do that's a little bit more universal to how we can impact across the board in our cancer plan and all of our work groups, with things such as policy or things that we are doing to really kind of elevate the conversation when it does come to the inequities that we are seeing. So, just in thinking about that, representation on our coalition is going to be a continued focus throughout our 21 year and beyond. So as you've heard, there's some things that are in the works to continue that effort, get those voices around the table so we can press forward the way that we need to be what we need to be to meet those needs. So again, thank you. I hope that you really found some good new information or heard from a group that you were eager to hear from, and we'll continue to do such things as we move forward. I'm going to transition us to okay, the slide was a little slow, sorry about that, to Brenda, who's going to talk a little bit about the cancer disparities that we are seeing very specifically here in Pennsylvania with males by race. So Brenda, if you could come off of mute, I'll let you take the reins here.
Okay, perfect. Good afternoon, everybody, and thank you to all the work groups and previous speakers today. Really good information and a good lead-in for this slide set. Taking a look at men's health and disparities by race, and kind of looking at it, not just cancer, but framing it with some chronic disease information and other types of information that I think were alluded to earlier by Jim. So we'll go ahead and move on now. Next slide, please. And I wanted to start here with just Pennsylvania's population. There's almost 13 million Pennsylvanians, and out of that, 80% of the population are white, 11% of that population are Black and African American, and then 5% Hispanic and Asian. So we kind of know what numbers we're talking about as we go forward. And out of the total population, roughly 49% are males, and out of the Black an African American population, that's about 48% of that population are males. Next slide, please. Okay, so this slide shows just a general health landscape for it's male or female. It's not by sex, but it's by race. And if you look forward, moving from left to right, this survey asked a variety. There were a variety of questions answered, and the first one was, you know, do you have fair or consider yourself to be in fair or poor general health? And the bars that are outlined in yellow indicate the higher rates. So you can see a significantly higher rate of Blacks and Hispanic, and the Hispanic population consider themselves to be in fair or poor general health, followed by the next grouping of smokers, and it's that same, you see a higher rates in that same population, the Black and Hispanic population here in Pennsylvania. And then moving along, and I apologize for that clock, moving along, they asked if you had a medical home, and again, you can see that African Americans and Hispanics, that really jumps up there, claim to not have a medical home or regular provider. So that's kind of an important one. The next one shows or asks about having a checkup in the past 2 years, and we see Hispanic rate pretty high there, followed by whites, and I wonder if that is our rural Pennsylvania, if some of that information comes out of that group. And then moving along, we're looking at obesity, and again, we see elevated rates among the Black and Hispanic populations. And same thing, we keep going, frequent mental distress. When you look at diabetes, that rate is highest among the Black population here in Pennsylvania. And then taking a look at the last slide, poverty rates, and the poverty rate significantly higher among Black and Hispanic and the Hispanic population. The poverty rate in Pennsylvania is across the board is about 12%. And then by race, it jumps up to 27% for Blacks and 30% for the Hispanic population. So if you think back to that population data, those are pretty significant numbers. Next slide, please. And then I wanted to take a peek at the current situation, and that's how COVID-19 is affecting race. And this slide shows the national data associated with hospitalization rates by race and ethnicity. And you can see the bar to the furthest left is the Hispanic or Latino population, and then non-Hispanic, American Indian and Alaska Native, followed by non-Hispanic Black population. And those are significantly high rates in comparison to the rates for Asian, Pacific Islander, and non-Hispanic whites. I did look on our Pennsylvania COVID-19 dashboard for this same information. And the reason I didn't use it, but it's worth looking at. We are gathering that data, but unfortunately, I think when information is being reported into Pennsylvania, into the dashboard, there wasn't a lot of race information. So when you look at that, and I would encourage you to look at it, because the good thing about it is it's kind of in real time. It's kept up to date, but it shows here in Pennsylvania a high rate for whites, and then the second highest, almost equal to that, it says unknown, and then followed by Black African Americans. So you know, it doesn't really show us the same picture that we're seeing nationally, but I suspect it's probably that unknown group is probably a high percentage of our minority group. Next slide, please. Okay, so then I decided we're going back to Pennsylvania specific data. This is the overall cancer incidence for males in Pennsylvania by race. And the green line, the lower number represents the Asian population. The gray bar in the gray line in the middle, trend line in the middle, represents white Pennsylvanians, and the top line represents Black and African American Pennsylvanians. So overall, you can see that it's been trending downward, and this is from 2000 to 2017. But there's still, so the gap is closing, but the rates are still higher for African American men than they are for Pennsylvania males of other races. And in general, and high in general, between white and African American males. Next slide, please. And then this next couple of slides will look at specific cancer trends for Pennsylvania males by race. And again, you can see, so looking from left to right, lung and bronchus, cancer incidence. That again, we see African American males, the rates are higher than for white Pennsylvania males and Asian males. And just a note, there was not data available for the Hispanic male population specific to them. And then again, colon and rectum, we are seeing that gap. That's kind of looks like what Nathan showed. It's kind of going up and down and up and down. So it'll be interesting to see what that looks like post-COVID, when in a couple of years' time from now, when we're looking at this year's data, who really was adversely affected by this pandemic and the economic crisis that it's created. Next slide, please. And here again, the same group, males by race in Pennsylvania, and a pretty significant rate increase for prostate between white males and African American males. And the same thing over here with liver cancers, that where again it looks like we've got a little bit of a downward trend right now after a pretty significant climb from 2006. But again, you still see that the rates are definitely higher for African American males than they are for white males across the board, or Asians. And actually the Asian rate's pretty high too. Next slide. And then we look at kidney and then myeloma. There was not significant data for the Asian population for these two cancers at this point. But you can see again where for kidney and renal, it looks like an upward trend towards the end here at 2017 for African Americans. And it's really been all over the place with not a significant downward trend. And actually it's trending up a little bit for white males as well. And then myeloma, a significant trend for African American males here. Looks like it's, kind of trending up if you just started with a straight line across from 2000 to 2017. So something that we'll definitely want to be looking at. But the picture it shows is, in general, we have higher rates of these cancers for the African American male population. Next slide, please. Okay, and this slide I thought was interesting. It takes a look at the national cancer morbidity and mortality by race and sex. So the picture to the left is the number of people who are diagnosed with cancer by sex and race and ethnicity. And if you look, the bars to the left indicate the males, and to the right of that, females. And across the board, these rates are higher in males. And then if you look at that third bar down on the left, that represents Black males nationally, and their rates are even higher across the board. And then looking to the right, the mortality rate for cancer by race, a similar picture. And again, this is nationally, but it shows higher rates for males of all races, and out of the males, higher rates for Black males. Next slide, please. And then bouncing back to Pennsylvania data, this is a picture of survival rates, cancer survival rates for males by race, excuse me. So again, this is pretty significant, and this is off of our data for 2017. It's representative of all cancers in males. And you can see a significant survival. There's a significant rate gap between white males to the left, and then Black males and Asian and Pacific Islanders. So that's a pretty important slide there. And if you could move on, please, to the next slide. And then again, kind of going back to look at race and other chronic diseases, including cancer. This is a 2016 death rate, and it's simply comparing Blacks and whites. And you can see, again, higher death rate in general. When you look at cardiovascular disease, which is the second grouping from the top, that's higher in Blacks. Heart disease, again, higher in Blacks, and same for total cancers. So it's definitely painting a picture of some disparity related to chronic disease and death rate. Next slide, please. So as part of the wrap up, I just wanted to include this piece. Probably most everybody knows who this is, and that's Al Roker, the NBC weatherman. And I kind of thought that this was interesting when he recently announced his diagnosis of prostate cancer. And I actually was watching him that day when he did that, and it was found really by just having a routine physical and routine blood work. And, he commented about really, he was completely asymptomatic, no symptoms. And also that he didn't really know at the time the prevalence of prostate cancer, and particularly the importance of Black males being tested for this as part of their routine care. So nationally, 1 in 9 men are diagnosed with prostate cancer, and the disease is more likely to impact older and African American men. In Pennsylvania, the rate is also 1 in 9 for Pennsylvania males. 1 in 45 Pennsylvania males will die from prostate cancer. And the risk for white males in Pennsylvania, 10, and then compared to the risk for Black males, which is 1 in 7. And as far as the mortality, 1 out of 47 white males in Pennsylvania will die from prostate cancer, and that number is 1 in 28 for Pennsylvania males Black males and African American males. So that's, again, I think that's pretty telling that we need to, I think men's health in general is important, and we need to prioritize that. And most definitely we need to look at Black and African American males in Pennsylvania and really nationally, and prioritize their health as well. Next slide. Thank you. So in closing, just a few discussion points, and that's cancer groups in the United States. But due to social, environmental, and economical disadvantages, certain groups bear a disproportionate burden of cancer compared with other groups. And that's kind of why I wanted to show other chronic diseases and, you know, and the poverty data, because these things all kind of tie into that, that burden. Cancer disparities can also be seen when outcomes are improving overall, but the improvements are not seen in some groups relative to other groups. And I think that we have seen that in a couple of these, some of the data about specific cancers. Although cancer incidence and mortality overall are declining in all population groups in the United States, again, certain groups continue to be at increased risk of developing or dying from particular cancers. And as we saw on previous slides, and other chronic diseases. Certain groups in the United States experience cancer disparities because they're more likely to encounter obstacles in getting health care. People who do not have reliable access to health care are more likely to be diagnosed with late-stage cancers. And then again, people with low income, low health literacy, and other obstacles like travel to screening sites, lack of insurance, or paid medical leave are less likely to have recommended cancer screening tests and be treated according to the guidelines. And I think that's an area where the men's health work group, that's something we can look at when it comes to prioritizing men's health with employers and other organizations. And then lastly, the built environment can also influence behaviors that raise one's risk of cancer. And so again, it's the neighborhood that you live in, the ability of healthy food and safe areas for exercise. I can, refer back to the obesity rates on an earlier slide. All of these, which are risk factors for cancer. And I believe that's it. So if anybody has any questions, I think, in general, I just really wanted to show sort of the big picture, both current and ongoing, the trends as far as men's health and the racial disparities associated with cancer and men.
Thank you so much, Brenda.
Thank you.
And I think we have some stuff that's coming in the chat. Let's see.
Yeah, I actually see what Sean wrote about tying together men's health and worksite outreach. I think that, employers need to, prioritize, well, we all do, not just the health of every Pennsylvanian, but certainly men's health, because as it was pointed out earlier, they're less likely to advocate for themselves. So if employers and other groups advocate for them, maybe we'll see an increase in participation with screenings or, seeking out services, whether it be healthcare services, insurance services, those kinds of things.
Thank you. Other questions or comments, things to ask while we have Brenda? Brenda, the question is, when did we, oh, I'm sorry. It's when we did the survey about prostate cancer screening, a large group of men who had insurance but never been screened cited work hours as a big barrier. Great point, Heather. No problem.
Yeah, and I think there's some work being done with employers in within the cancer division for breast and cervical, and that's something we've been having some conversations about. You know, how to kind of capitalize on some of their activity and resources to do this very same thing for men. So I think that's something that we really need to put our heads together and think about as a strategy moving forward.
Brenda, this is Lynn. It never used to be a problem. I have years of experience working with men in the workplace, but that was a time when prostate cancer screening was recommended. The minute that changed, now, you know, according to the U.S. Preventative Task Force, it was a D. Now it's gone to a C. Some of my urology and oncology peers tend to feel that we're going to see somewhat of a comeback of screening, at least in high-risk individuals. You know, you can have the informed conversation with them, but you can't just routinely screen as we used to do. So that then sort of took it out of the workforce. You know, it wasn't as interesting. But hopefully we can make a pull for it again and maybe, you know, just think out of the box in those regards. Because I know at our institution, I cannot just routinely screen for prostate cancer. I can screen for a lot of other things. I can screen high-risk men, but I can't just screen like we did at one time, like you do for a woman with mammography or for cervical cancer.
Yeah, and you know, one of the things I think, having been an endoscopy nurse for 30 years, you know, if men go for colonoscopies, they will get their prostate checked under anesthesia. It's
right.
Every single endoscopist I have ever worked with, the very first thing that we do. And, you know, I mean, I think it's just information like that. Like, you know, if you go to your provider and you know, you can get multiple things assessed. You can, you know, they'll check your blood pressure. They'll, you know, there's just getting them in the door, you know, to start is key. But even just bundling that information, like, you know, it's kind of like a 2-for-1 if you go for a colonoscopy.
And, you know, there's a lot of PCPs that automatically do the screening, you know, routinely. I know my husband every year, it's just on the PCP's docket, and she's a female. I mean, so it's just amazing. I think we need to get men to advocate a little more for their own health, and then they could ask for these things. But that's going to take some time, but we can get there.
Great points.
I wonder, is it really to the discretion of the physician alone or to the institution, as you mentioned earlier? I think it was Lynn.
Yeah.
Who's in charge of that decision and policy making?
Sharnita, that's a very good question. I mean, physicians can do it. It can be the discretion of the physician, but when you have a service like I do, that I'm out in the community screening, and particularly low income and disparate populations, I have to go based on what the recommendations are and what our medical director says. So I think it can vary, but you can, you know, also have, you know, once you've had the informed decision-making conversation with the patient, they can become their own advocate and say, I want it anyways. And then it can be done. You know, you just can't just be routine offering it as we once did. So I think it varies. It could vary per institution, because I understand some institutions in the Pittsburgh area actually do routinely do prostate screening.
Thank you. Some really good discussion and great points. Thank you again, Brenda, for sharing that. There was definitely some wow pieces of information in those slides. We're going to transition and return to Heather, who's going to take us a little bit of that summary of that good content that was shared earlier today around kind of that learn from the past. So Heather, if I could turn to you to walk us through this slide.
Yeah. I was wondering that since I updated this slide, if I could show my new slide. I'm sorry.
Not a problem. If you just want to grab control, that's fine.
Okay, great. The control option isn't available for me this time.
Let's see here. I can change that quickly. All right. All right, so that should change now. You should be able to see that.
Thank you.
Very good.
Okay. I actually have I made a whole other presentation, but we can just, in the interest of time, we can just focus in on the final slide. So first of all, I wanted to say that the evaluation subcommittee and also the Department of Health cancer staff and also the leadership group take these results of the survey very seriously each year. And so we presented our report to the Department of Health in September and then to the leadership group, the executive team shortly after that. And then people already started making some movement on some of these recommendations that we talked about in the morning. So some of the things that we recommended are already underway. But these are kind of the 6 themes of things that came out over and over between those different areas. And I thought we could discuss some additional ways that we might be able to do some of these things. So one of the big themes that came out is that although there's been some movement towards improved communication within between PCC members, that there's still some room for that to improve more. So I don't know if we wanted to, I would like this to be interactive rather than me lecturing at everyone. So it would be great if maybe some of the folks here could bring up some of the ways that they've enhanced communication, especially the communication subcommittee. I know that you all are working hard on this, but I can review some of the things that I know about if that's easier. So I guess I would like to hear from folks about what would be the most engaging way to do this for you all.
Heather, I think maybe starting with some of those things that have been heard, and then maybe we can kind of play off of that to start generating that discussion.
Okay, so then I am going to go back into some of this. So some of the initiatives that we have been working on to improve communication are, number one, there's pacancercoalition.org. And so that really is becoming a clearinghouse used to disseminate information. So for example, if you want to take a look at the full report with all of the answers to the surveys except for the barriers and the things that are important about participating, and any of the data that we have about the outcomes specifically for the comprehensive cancer program, and how the plan was implemented in the past year, you can go to pacancercoalition.org and find that report there. There's also any news that is submitted also goes there, but I think that it's still being a little bit underused because it's still a little bit new for everyone, and we don't necessarily think of that as the place to go. but I think that we're increasingly going to be seeing that used as a depository of clearinghouse for materials like the slides from this morning I know are going up there too. Right? So there's also been some extended education communities at virtual CAB PCC meetings and doing exactly what we did today, where we got to hear from all of the subcommittees and work groups about what's going on, is a really helpful and valuable way for me to understand what's going on. But it seems really clear that there was a lot of interaction in that first section of this afternoon about people seeing ways that they can collaborate together. And that's exactly what we hope to see when we said that there needed to be some more communication between groups. Another example is things like Nathan doing a walkthrough of the data resources this morning and Brenda saying, hey, I know that we need to talk about disparities in men's health. And those are also directly in response to comments and survey results about data availability. We didn't really see improvements in what people thought about data availability, so we want to make sure that people know how to get data and the are available and being discussed, especially around disparities. So what are the newest things that are happening? What other initiatives are people thinking could potentially improve shared decision making and communication?
Heather, I think one of the things, this sort of has been coming up, not even just to our Pennsylvania Coalition, but to just other things as we've all been, kind of navigating virtual meetings and gatherings and stuff like that this year, has been the space of kind of, the networking. So I think that's something, we'll really be looking at how we can do that in this space moving forward. And that may be even if anybody has had a good idea on how we can do that. But I know that that's something that we always found tremendous value.
This morning, I talked a little bit about how I know that's a really valuable thing at the PCC meetings in person that we're missing now. But I don't have a good recommendation for how to make it still happen.
What I also think is a little difficult, I'm sorry. What's a little difficult, Heather, is, we have such few responses. And I know that's not abnormal if you look at surveys and you have about a 10% response. That's not so bad. But it would be really great if we had more responses to really see if this is truly what the majority of the group is feeling.
Yeah. So I can say that even though it's only about 10% of or a little more than 10% of the overall number of people who are on the list, it's about, most of the people did attend at least one meeting, and that's more like 1/3 of the people who attended a meeting in the time period.
Heather, this is Jen Pensinger. I'm one of the co-chairs of the communications committee, and I will tell you that both Lisa and I, we've really felt that we've been struggling over the past year. And so just, maybe 3 months ago, we decided to do something different, and we put a call out to all of the different work groups and subcommittees to find out if they wanted to appoint one person to serve on our committee with us, because we've really felt that, we have this great website, we have some things, but it's really been a struggle to share all the great things that are happening because we just don't know everything that's happening. So we have started to implement that, and we're hoping that will really increase some communications. And I know Monica's going to talk more in a little bit, mention, I guess, for now too. that if anybody is not, if you're one of the work groups or the subcommittees who has not, appointed a person to join our communications subcommittee, we would love to have somebody from your group. So that's some of the things that we're trying to do on the communications end, because we know that it's hard to really communicate all the great things that are going on.
Yeah, thank you. That's great. And
Sure.
I also want to say that the evaluation group is going.
So Heather, this is.
Go ahead.
No, go ahead.
I was going to say that the evaluation group does plan to do some strategic planning to try to get more engagement in the survey, and possibly will call on subgroups, subcommittees, and work groups also. But we don't have a plan yet, so stay tuned. Okay, sorry, who was I interrupting?
So hi, this is going back to a little bit, that's fine. To what Jen, it's not like we can raise our hand like, again, we're in the same room. So I had a thought regarding participation in the work groups. And I know most of the work groups, and I think the subcommittees as well, meet on a regular basis. But that information is not shared easily across work groups or subcommittees, or vice versa, for the flow of communication. Is there a way of maybe having a master list of, like, if everyone meets the first Thursday of the month, and have a dedicated, like, Zoom or whatever Microsoft Teams link that we can keep up on Live Healthy for those coalition members and CAB members that would like to participate in, calls of the different subcommittees or work groups?
That's a great idea.
So I can't, excuse me, this is Monica. I can't speak deeply to it yet, but do know that I've begun to engage PHMC, who is our vendor that hosts our websites, to begin the discussion about different functionality that we might have on the PCC website that would allow for some streamlining of that communication or calendar, also some email functionality. But those things are in the very, very early stages, where I'm looking and thinking about how do we use the technology that we have more effectively and more efficiently? And is it a way to utilize that where it doesn't cause us all to have one more thing that we really have to do? Like, how can we balance that with all of the other hats that we wear?
Yeah. Thank you, Monica. Okay. So another one of the things that kind of came out of our findings that we discussed earlier is that PCC members have expressed concern about the representation in the PCC, both in terms of the demographics of the people there, and that we need more survivors and caregivers who can serve in a dedicated role as a survivor and a caregiver and not have conflict with their other hats, and also some of these specific legislators, payers, representatives from state agencies. So that also ties in with the idea that new members of the PCC are not always oriented to their role. This has improved over time. Longer tenure members know what the history is like, and so they're more likely to agree with this, but there still is a way to go. And this is, again, this is a pretty normal thing for coalitions. It's really complicated to be in a coalition. There's a lot going on all the time in different ways. It's just that it's really important to make sure that we have those structures in place so that great people want to join, and then we are able to make them feel like they're able to contribute, and we get the best of them and they get the best of the PCC. And so there have been a whole bunch of things that have been that are underway that we're working on to try to get PCC recruitment and new member orientation. There's the creation of the new member subcommittee. There are conscious efforts to recruit advocates from disproportionately impacted communities. There are some conscious efforts to recruit people by specific subcommittees. And orientation and onboarding improvements for new members have continued to develop over the years. And I believe there are some improved attempts to link to work groups and subcommittees of interest. And I think that I heard that we are trying to start some kind of mentoring or buddy program. And I was wondering if somebody could talk a little bit more about that. And if not, then what else could we do to try to make sure that we have the right people and that they are basically trained to work well with the PCC in all its complicated beauty?
Heather, this is April, and I don't know if Casey is on the call or Dave as well. We have established the membership subcommittee, and one of the first tasks is developing a welcome letter and an orientation information packet. So it's a one-stop shop for new members. And then someone from the membership of the subcommittee, either the leadership or a member or leadership of the PCC, will hold a video conference call with them to kind of introduce them to the CAB, the PCC, what are roles and responsibilities, orient them a little bit to what are the priorities and what the work groups are working on, so they can, you know, identify that they've adequately chosen the subcommittee work group or more than one that they would like to work with. And we could utilize then, as we're talking about this, those that are on the membership subcommittee as maybe the identified mentor or the go-to that that person could reach out to ongoingly to, you know, answer questions, help orient them, guide them where they need to go. Kind of wanted thoughts maybe on that one.
Do you think that it's best to do it with the membership subcommittee, or that they should be paired with somebody in the subcommittee or work group that they want to join? Or does anyone have other ideas about that?
I don't. Yeah, I was just putting that out there, that that's a thought of one way to accomplish that.
No, yeah. It was an actual question, not a
Hi, this is Ruth. I think linked with someone either on the subcommittee or the working group that you're on, it probably helps the orientation better, because you get more of that, get more of the feel of the fit of your work and the work that you're doing within the PCC.
Great. Okay, let's move on. I want to go back to the emerging themes.
Heather?
Yes.
In the interest of time, if we could maybe kind of spend maybe 2 or 3 more minutes on this, and then we can transition.
Yeah, those were my main points. I wanted to say that I think that one of the things that also came up is the virtual accessibility thing, although we kind of addressed that virtual accessibility is great, except when it isn't, and we have that challenge with trying to replace the networking. Another area of work is clarity of roles and responsibilities for everyone, including within work groups, to make sure that everyone is able to contribute the ways that they're able to best contribute. And so that might be something that each PCC member and also each subcommittee or work group leader can think about. How can I make sure everybody is engaged, or how can I step up? What do I have that's really unique that fits in here really well, that I see a need for? So that's what I have. If anyone else has things that they would like to respond to, or great ideas for how initiatives could work, it would be great to hear that in the next 2 minutes. And if not, then I'll give control back and we can hear more from Monica.
Heather, if you could pass that back to me.
Yes.
All right.
Okay. All right. Thank you.
Thank you. All right. So we are going to gather Monica's slide. And then Monica, we're going to go right into you and the communications thing. So I'm going to get all the way to the end slide here if you want to come off of mute. Monica, are you there?
Yes, ma'am.
Okay.
Just waiting to get to my slide. And while we're waiting, you're going to hear from probably Jen from the communication subcommittee, and also Mark about a few of the points that I have on my slide. One back. You can tell from all of the discourse, and especially since our annual meeting, it's really been about improving connectivity and sharing of the various resources that we have. And during, I guess, the last 3 or 4 months, there have been several people who talked about going to the coalition website and not realizing that it was so much information that was there. But to this point about communication, it really is a two-way street. And almost everything you guys talked about today in one form or another could be added to that website, or sort of used as a basis for that intercollaboration with the various subcommittees and work groups. I think I'm just going to drop down. What I'm going to do is I'm going to drop down and talk about our continuing in the virtual space. After that, I'm going to pass it off to Mark to talk about the PCC LinkedIn account, because he established that. And then after Mark, we'll go really quickly to Jen so she could talk about a little bit more in depth, and we can share the conversation if she needs about some of the communication subcommittee strategies that we've been using. In terms of continuing in the virtual space, the Department of Health, the state, the Commonwealth of Pennsylvania has been moving to Teams. This has been as you know, a rollout with different functionality available at different times. It is our hope that in the coming year, we will be able to provide you with those breakout rooms in this virtual space that you'll be able to use that will serve a similar function as it did in person. Also, we're looking to have evolution to functionality for polling, so that we can maybe collect some of this data as we ask you questions, and people could really begin to interact with the presentations in a way that keeps them engaged. And we could collect some of the data that we're asking right then and there, and then be able to look at it once we got offline. All of our meetings are available on the website as recordings for download. And we will be posting today's presentation, or at least Nathan's portion, up on the website. Kate and I had the pleasure of sitting with our Microsoft government space liaison to talk about some of these new functionalities, especially the breakout room feature. So we're kind of excited about that. From here, Mark, are you still there?
Yes, I am.
You want to talk a little bit about what your vision and ideas were for the PCC LinkedIn account?
Sure. Yeah. So, I think, what we had aimed to do from a social media perspective is at least have a presence for the PCC. Apparently they let anybody with any credentials create accounts in social media. So I took the liberty of just creating a Pennsylvania Cancer Coalition LinkedIn account. We also have a Twitter handle out there, so watch out. Again, to try to preserve that kind of space for this coalition. It certainly hasn't been a extremely active platform, although it's kind of, we have the tool there, we can leverage it a lot more. I am going to go ahead and post the direct link into the chat so people can jump out and explore the page. A nice thing about having the page out there is that it is established on LinkedIn as within the LinkedIn professional space, which again, LinkedIn is owned now, the parent company is Microsoft. So it's going to have some longevity to it as far as LinkedIn is going to be a pretty stable professional platform for us to kind of link us together as professionals in our respective areas. But I think that the nice thing about being able to establish the PCC in this account is that as individuals and as members participating here, you can go on to your own account and you can kind of add the Pennsylvania Cancer Coalition as a current employer in a sense. You can add it to your employment history and state yourself as a member, or if you're a co-chair or a participating member of a subcommittee or work group. And kind of use that as a badge in a sense that make sure that your contacts know that you're an active participant, you're a member of the PCC, and they may say, hey, what's that about? And it actually is helpful to drive more traffic to our LinkedIn page, and our LinkedIn page really serves as a conduit back to the PA Cancer Coalition website, where there's a whole host of other information and content that we're going to be driving. We'd like to drive those that are interested to that content and to those resources. So, I would say consider, if the website is, really the room where all the collaboration happens and we kind of coalesce our materials about our activities, then, the LinkedIn page is really kind of that bulletin board that's outside the room. It's to highlight a number of things. It's to gain reactions in a public space and drive more interest to our website and more of that content. So I think from a vision perspective, that's kind of where it would fall into place and how we hope to use it. But I'm not a pro when it comes to the social media strategy. So it is a resource for the coalition, and I'm happy to help facilitate that or provide others with access if they have ideas on how to, promote that and keep it active. So.
Thanks, Mark. Jen, you still out there? You want to pick it up and talk about what's going on in terms of the communication subcommittee and what some of our planning is?
I am still here. I kind of shared a little bit more earlier. We are just looking for new members for the communication subcommittee. Our goal is, like I said, to spread the word about all the great things that each group is doing and on a whole. So we really encourage you to send us things to include on the website. And we also want to let people know that if you have interest in joining the communication subcommittee, we are looking for members. We meet twice a month. I forget if it's the second or fourth Tuesday. I'm not sure how it works, but we try to have shorter meetings. And if you're willing to come on from a subcommittee or a work group and you just want to share, brief highlights and get right off of the calls, that's fine with us too. But we want to encourage people to send us stuff so that we can keep getting the great information out there on the website as well.
So thanks,
Did I
Jen.
miss anything, Monica?
No, you didn't miss anything. And one of the things that I want to add is, you know, as members of the coalition and even members of the CAB, if you have something, you could write a short article, a white paper, your reports, any of those items that are focused on the work that we're doing can be, you know, looked at to go up on the PCC web for us. And I think that's basically it. We want to engage more. We think too that we might be a good place for you guys to maybe have some sharing of review of materials or get our input. I know that there were certain providers and people in the professional space who were interested in health literacy. And of course, this health equity topic, as it should, is really important and should be integrated across the continuum. So there may be opportunities for us to do things around that and have videos. We don't always have to have the big $15,000 sort of video program, even though that's great. We can do things with the technology that we have and the expertise that we have to even develop our own information, our facts and things that we want the community to know about, just using the virtual space. So that's something to consider as well. And with that, that's all I have. Thanks for letting me share with you guys.
Thank you so much. Yeah, Lynn, sorry.
That's okay.
All right, so I'm going to transition to our last slide here. So first and foremost, thank you all for your time today, spending the entire day together to talk, dialogue, hear, and learn. We definitely have had quite a interesting year, this 2020 year, and it has brought new changes, new space, new opportunity our way, and opportunity and new thinking as we move into 2021. So as you've mentioned, really those themes throughout as we are kind of winding down and also gearing up. There's things that will be kind of coming your way to how we meet as a coalition in the year 2021 that we look forward to, and seeing how we can kind of have some of that space that we had before, and then kind of bring that to our new virtual world through breakouts and opportunity for networking and such. So really with that, again, just massive thank you for the questions, the dialogue, and just really that interaction. Lynn, I'll also turn it to you for any final words that you want to say, and we'll go from there.
I just would like to also say thank you for all the hard work you've done over this year and prior years. And I know as I listened to everything today, I wrote down a few notes and a few people's names that I'm going to reach out to because of what I heard in the presentations that may be willing to join the PCC and specific work groups. So I'm hoping some of you were doing the same thing and keeping in mind the health equity and the disparities and the individuals and groups that we need to bring to the table because we do need to grow the coalition. What we did set as one of our goals for 2021 was really in order to achieve all the goals that and meet all of our outcomes, and is that the fact that we need to get more people on the ground doing the work. And unless we're in the communities and actually delivering the messages and moving things forward, we're not going to achieve everything we want to. So with that in mind, again, thank you for everything, all your time today, all your participation, and everything you do in your busy, busy schedules, and happy holidays.
Absolutely,
Kate,
yes.
Back to you. I feel like the letter.
You said it beautifully. So yes, with that, we'll do a conclusion of our meeting and really wish you well, wish you good health, and a good couple of weeks as we close the year. So happy holidays, happy new year, and see you in 2021. Thank you so much. This meeting is adjourned.
Bye-bye.